right, good morning everybody.
Good morning.
And thanks for coming to our session on evidence-based strategies in augmentative and alternative communication. My name is Oliver Wendt. I'm an assistant professor in speech, language and hearing sciences at Purdue University. Can you all hear me in the back? Not using a microphone? Yeah. I know I have a very strong German accent, so if for any reason you can't quite get what I'm trying to say here, feel free to interrupt and I'll be happy to repeat. For our program this morning, I'm planning to walk you through some of the more prominent AAC strategies for individuals on the autism spectrum and for those that have developmental disabilities. In more depth, we will cover manual signs and gestures, picture exchange communication system, and then speech-generating devices. And for the later part of the session, I was planning to show how these strategies could be combined in a trajectory from starting with low-tech and then moving the learner slowly onto more high-tech solutions. In my research lab at Purdue University, we are focused mostly on individuals on the autism spectrum. Most of these people show a triad of symptoms with significant deficits, impairments in three major areas. There's usually an impairment in language and communication, an impairment in social interaction, and restricted and repetitive patterns of behavior. One of the core symptoms is a delay in or lack of the development of spoken language. And if we're looking at the entire autism spectrum, the numbers tell us that about 14 to 25% of these individuals present with little or no functional speech. If we are looking at those that just have the autistic prototype disorder, then up to 50% of them would present themselves as functionally nonverbal, which means they don't have sufficient natural speech or language to communicate their daily wants and needs. And this is when they become candidates for intervention in augmentative and alternative communication. The strategies that I'm going to present don't just apply to children with autism. There's also others with related developmental disabilities, particularly those that have intellectual disability, where this would apply to as well. When we talk about intellectual disability, we usually refer to this as an umbrella term for a large range of syndromes and conditions that result in cognitive impairment. Most commonly, along with cognitive impairment, there is some difficulty with spoken communication. Many of these individuals do not use speech as their primary mode of communication. On top of this, there's a high incidence of problem behavior. Cerebral palsy technically also falls under developmental disabilities, but we won't talk too much about cerebral palsy this morning because their motor impairments, their motor issues demand a different access solution, especially when we are talking about communication devices, and that is a topic of its own. As far as the prevalence of intellectual disability, it's estimated at 1 to 3% worldwide. In the school-age population, we estimate that this is the largest proportion that has some type of need for AAC supports. Buchanan and Miranda estimates that up to 38% of preschool-age children with intellectual disability have actual AAC needs, and there's a larger organization, a joint committee that looks out for the needs of people with severe disabilities, and they are saying AAC is a crucial need a crucial part of service delivery for this population. When it comes to autism and developmental disabilities, there are three major strands of AAC strategies that stand out. The first one is manual signs and gestures, then pictographic symbols and systems, and then with advances in high technology in recent decades, there's more of a push, more of a trend towards using what is called speech-generating devices, electronic communication aids that provide synthesized and digitized speech output. When it comes to select a suitable intervention approach, practitioners are often faced with the difficulty deciding between these different strategies. And the mandate these days in healthcare, in education, speech-language pathology is incorporating evidence-based practice using research outcomes as a major basis for clinical and educational decision-making. So while presenting the major AAC strategies, I'll always try to go back to the research literature and support the presentation by actual empirical data. So the first strategy that was applied to individuals with severe communication disorders in general, particularly those with autism, developmental disabilities, was manual signs and gestures. Manual signs are an unaided form of communication, and what that means is we're not relying on any external aid. We can communicate with our body only. Historically, the oldest form of augmentative and alternative communication was introduced in the 1970s and used successfully for more than 30 years. When we say manual signs, we often refer to either a natural sign language, such as American Sign Language, or to the production of just a limited repertoire of manual signs just to get functional communication going. By the mid-80s, there was an approach called total or simultaneous communication, where practitioners combined speech with a manual sign to enhance its intelligibility. And this approach was then labeled as SC, simultaneous communication or total communication. Gestures are somewhat different from manual signs because for gestures there are not these linguistic rules or syntactic rules how to produce the motor action, whereas for the manual sign there are very concrete instructions. How exactly are you supposed to move your hands and fingers to produce the accurate sign? Why are manual signs a choice that is relatively prominent in the AAC community? Well, first of all, manual signs are relatively easy to imitate. Individuals that are on the autism spectrum may have difficulty producing words through their vocal folds, but they might display strengths with imitating motor actions. Signs are less transient than words. What that means is a spoken word, as soon as I've said it, it's already gone, it's over. It doesn't stay on very long. Whereas with a sign, it can take a few seconds for me to produce it, and you can look at it, you can see the sign for a longer period of time, and that can help with cognitive processing. And that might also be why this is less frustrating to learn than vocal speech. Many of those with developmental disability, autism, have a negative history of learning how to speak, and then an alternative mode, such as manual signs, can be more motivating. The empirical evidence is relatively in favor of using manual signs. You can use manual signs basically for two different purposes: to get expressive communication going, give the individual a better way of expressing, get functional communication going, and so forth. Or you can use it in a way to enhance receptive understanding of the spoken word. As far as that expressive channel is concerned, there are 5 more high-quality studies. When I refer to empirical evidence, I will limit myself to experimental studies, because this is the preferred evidence in evidence-based practice. I'm not talking about case studies and anecdotal reports and these lower levels of evidence. Just experimental studies are mentioned here in this presentation. In this experimental research, there are particularly 5 studies that include 22 participants, and they looked at how well do these individuals, when they're being taught manual signs, and can they use that as an expressive mode of communication. And of course, all of these experiments, the outcome was highly effective. When you measure intervention success, you quantify this, how much progress was being made from pre-treatment, post-treatment, the effect sizes turn out to be highly effective. For simultaneous communication, there are little bit mixed results. In one experiment, simultaneous communication turned out to be superior to sign alone and oral training, meaning just teaching them to say words. In another experiment where they compared simultaneous communication versus sign alone training in 2 participants, there was no experience, and another little larger group study found that the sign alone condition was actually superior to simultaneous communication or just oral instruction. So a little bit of mixed results there. As far as receptive speech is concerned, the ability to understand speech better if it's accompanied by a manual sign, again, we've been seeing superiority of the manual signs over sign alone in this experiment, and strong support for using manual signs as part of simultaneous communication when the 3 participants were taught in this experiment by Kerr and Doris. So in summary, for both groups of experiments, for these two strands of research, the expressive speech and the receptive speech was enhanced by manual sign instruction, and all of these yielded relatively high outcome scores. So the empirical literature suggests this is a viable communication option. What might explain, what might account for its effectiveness are the following reasons. It seems to be a better choice than vocalizations because it's easier to prompt an action from a research participant than a vocalization. Signs themselves can be relatively iconic representation, you know, easy to understand even for an unfamiliar listener what is the sign for a drink. Versus the spoken word always has, is less iconic. The individual needs to understand when I'm saying table or chair that that stands for the exact referent in that particular environment. And like I said before, motor imitation is a relatively easier behavior to teach because a teacher can make use of physical prompting and fading procedures. Now, I have to say so that in recent years, particularly when it comes to individuals on the autism spectrum, the AAC field has moved a little bit away from introducing manual signs for the following reasons. More and more studies are telling us about motor control problems in individuals on the autism spectrum, saying that many of these students show some clumsiness, show poor muscle tone, show difficulty with fine and gross motor skills. And this is seen in about 80% of children with autism, but so far has not made its way into any of the diagnostic criteria. When we look at how much of a sign vocabulary is actually acquired in those participants with autism, we find that they acquire only a limited sign vocabulary, and the signs they produce tend to be poorly articulated. The other relatively big obstacle that AAC clinicians would criticize is once you introduce manual signs, you're limited to a certain social environment, and not everybody outside that immediate environment that understands the signs will be able to communicate with that student. In the late 80s, there was an experiment to support that hypothesis where two adolescents with autism were taught to order fast food with stuff unfamiliar to them, and they were taught to order it under two different conditions, in the manual sign condition, and then just using graphic symbols on a regular communication board. And only 0 to 25% of the manual sign requests were understood, whereas much more of their messages were understood once they started using the graphic symbol communication board. So these practical constraints make a difference for many of the individuals, many of the clinicians in the AAC field. In terms of future research, we urgently need studies that are comparing manual signs or gestures against another mode of alternative communication, such as pictorial systems or speech-generating devices. You need to know under which conditions is one of these strategies more favorable than another one. Also, the major philosophy in AAC always is and always has been creating a multimodal communication system where in certain environments and situations you would be using one strategy and you would be using another strategy when your primary communication mode breaks down or you need another type of alternative mode of communication with a different partner, with a different setting and so forth. This research also has not taken place. Research into effective strategies for teaching the individual when to use what type of AAC strategy. Let's talk a little bit about gestures. Gestures are much more simpler than manual signs, and they are defined as body movements or sequences of coordinated movements to represent an object, idea, action, but they don't have the linguistic features of manual signs. Examples for simple gestures are pointing, simple yes and no headshakes, and so forth. From a developmental point of view, these come relatively early in the developmental trajectory in speech and language. Individuals with autism, however, rarely use gestures as an alternative communication strategy, even if they have difficulty speaking. Gestures can be a good strategy to start out with. Like I said, from a speech and language perspective, they serve as a precursor to later development of language skills, so it makes total sense to target them. Gestural behavior is also a strong connection with social interaction. It helps to establish social reciprocity. And it's appropriate for early AAC intervention to get symbolic development going, to teach the child one thing, like a simple gesture, can stand for something else, and you're getting something else in return if you produce this simple gesture. The motor demands are not as much of an issue as with manual signs, so that also speaks in favor of gestures. Very interestingly, the empirical evidence on gestures, particularly for individuals with autism, is very limited at this point, and it boils down to just 2 experiments that would meet the criteria of experimental evidence-based practice. In that first experiment, gestures were taught in combination with oral speech, very much in the simultaneous communication mode, and they measured the frequency of correctly produced gestural and verbal responses, and all of the 4 participants showed high effectiveness, showed high performance when this was being implemented. In another experiment, the participants were trained in communicative pointing to obtain a toy, to obtain a desired item, and they measured the frequency with which that pointing occurred, and this strategy again turned out to be highly effective for all 4 of the participants. In summary, it appears to be that gestures seem an effective communication strategy, but there's very limited evidence at this time. Compared to manual signs, it appears that gestures are underrepresented and not well researched in this population. This is very surprising to us because of the strong correlation that gestural use has with initial speech and language development. More research here again is urgently needed to beef up the empirical support for gestural communication. Moving on to exchange-based graphic symbol systems. And graphic symbol systems in general can be categorized into selection-based, where you are pointing towards a graphic symbol that's put on a display on a communication board of some type, or into an exchange-based approach, where the graphic symbol is exchanged in return for a desired item. I'm going to focus on the later because these exchange-based strategies, in particular the picture exchange communication system, have become much more prominent in autism, in developmental disabilities, than the former approach. The picture exchange communication system, or PECS for short, is a structured behavioral intervention program that teaches the use of visual graphic symbols for communication. It's an easy instruction to teach the child making requests by handing over, exchanging symbols for desired items. These symbols are often put on a communication book, and within that book there's different pages, different levels, and the child goes through, picks up whatever the needed graphic symbol is, and gives that to a trainer in return for the desired item. There's an extensive protocol of instruction behind this, and it's divided into 6 different phases. In phase 1, the learner just learns this simple exchange act. You give me that picture card and you get your desired item in return. In phase 2, they are supposed to take their picture book, go from one place of the room to another place, and then make that exchange. And they're also supposed to make that one symbol exchange with different communication partners. In phase 3, they are taught to move from one symbol exchanges to 2, 3, 4, and more symbols. And what the critical skill that is taught there is picture discrimination. They learn to discriminate one graphic symbol from another one. In phase 4, the learner is taught to combine an I want symbol with the desired item to construct a very simple sentence of I want plus desired item. In phase 5, there's more of an attempt to get them respond to the question of what do you want. And in phase 6, they're supposed to use these strategies more spontaneously and also expand their repertoire from requesting to commenting. Why is PECS a choice of? Why would PECS be a good choice? First of all, it requires very few prerequisites. The only prerequisite basically is the individual can clearly indicate wants and needs. The first skill in PECs is thought requesting, and from a developmental point that makes sense. It's an early skill that you would usually teach in early instruction of individuals with developmental disabilities. It systematically targets spontaneous communication, which tends to be a particular deficit in autism. And the symbols that you can put onto your PECs communication boards, those can be highly iconic. You're not limited to the symbols that come with the original textbook. You can put on your own photographs, your own graphic symbols.